Hello. Talking about sleep disorders. Talking about insomnia. Hello. Oh, cool. All right. I think we're back. Talking about insomnia. So sleep disorders are going to be one thing that we're going to see patients for a lot while we're in practice. So talking about that, and also I feel like this is going to be a large part of our quiz content based on she asked us to pick between um, sleep disorders and the depression um, for our case study. So here we go. Insomnia, loss of sleep may be due to psychologic causes such as restless leg syndrome, GERD, fibromyalgia, or sleep loss because we're ignoring sleep cues, such as tiredness. We want to play our video game a little longer. We feel tired, we ignore it. And then eventually we just stay awake. Rest that is not refreshing can also be classified as insomnia. So it could be of physiologic or psychological origin. So before we label insomnia as psychological, it's essential to rule out physical causes. So we're going to look at H&P. Characteristics of chronic insomnia include somatized tension and acquired habits that prevent either the initiation or maintenance of sleep. Life stresses such as shift work, family tragedy, or physical pain can exacerbate chronic insomnia. So, short term insomnia can be in isolation or comorbid with mental disorders, medical conditions, or substance abuse. It additionally can be related to stress, either positive or negative. So, also circadian rhythm disorders, jet lag, rotating shift work, and probably just anxiety and stress that comes with like everyday living, I would think. Um, or if you just didn't eat enough, stuff like that. That's my 2 cents. All right. So insomnia is seen more often in people over age 65. Apparently, their circadian clock becomes advanced, causing early morning awakeness in older adults. So, don't know how that happens, but apparently, their clocks advance. Light cues are essential in the process of sleep. The absence of light signals tend to produce longer sleep wake cycles, which makes sense. Typical complaints of insomnia are malaise, fatigue, and too little sleep. Insomnia can be drug related, and also we can rule out psychiatric causes too. Sleep questionnaires, sleep diaries, screening tools for depression and anxiety can be helpful in evaluating our patients that come in with insomnia. Non-pharmacologic treatment includes evaluating the fundamental causes and treating the appropriate intervention first. So counseling, behavioral management, lifestyle alterations. So if you just want to play video games all night and then you come and complain to me about being sleepy, I'm probably going to tell you you need to have some better sleep hygiene and set an alarm to go to bed and stop playing your video games and have some self-control. Patients with insomnia also often have major depression, anxiety, obsessive disorders, dysrhythmic disorders, and psychotherapy to focus on specific psychiatric disorders. I'm on page 832. Light therapy can retrain people, especially like shift workers. They can retrain them to go to bed when they're supposed to. So, 2 major classes of drugs for insomnia, benzodiazepines and benzodiazepine receptor agonists. Also, you can put them on like a antihistamine. I feel like maybe starting with that would be a good thing, but the table 41.2 on page 838 begs to differ. So, the recommended order of treatment for insomnia, according to them, are benzodiazepines, the BZRAs, and then the first generation antihistamines. So your Benadryl, or your doxylamine succinate or Unisom. So let's talk about those ones. Our benzodiazepines. Um, so there can be short acting, intermediate acting, and long acting. Previously, the short acting agent was triazolam, but apparently that causes rebound insomnia. So we tend to stay away from that. So we'll go to the temazepam or Restoril, and Ativan, lorazepam. We all know that one, I would think. So temazepam and lorazepam are examples of intermediate acting agents, and flurazepam or Dalmane, never heard of it. It's a long acting. So agents with intermediate onset usually have longer half-life. So intermediate onset, longer half-life. Useful for patients with sleep maintenance issues. Those are their temazepam, Restoril, and Estazolam. Never heard of it, and it's only coming in generic form. So those two, Restoril and Estazolam, are good for sleep maintenance issues. So I have no trouble getting to sleep, but man, I can't stay asleep. So I'm going to have Restoril or Estazolam. Now, for another problem, two agents with a rapid onset of action, flurazepam and clozapam, assist with falling asleep and have longer duration of action, assisting in maintaining. So if I'm having a hard time, I'm just laying, tossing, turning, cannot fall asleep night after night. Having a hard time falling asleep and staying asleep, I'm going to put my patient on flurazepam or clozapam. Your Dalmane and your Doral. Never heard of them. So those are your benzodiazepines. Adverse effects, drowsiness, impaired motor function, we know that. Short-term memory loss, confusion, shakiness. Prolonged use of these benzodiazepines can lead to physical dependency. Abrupt discontinuance can trigger withdrawal symptoms. Interactions, alcohol, no alcohol with that. And then also erythromycin can decrease triazolam the clearance by 50%. So you need to reduce the dosage of triazolam. Yeah. Oh. Whoa. All right. The use of low-dose contraceptives may slightly decrease the clearance of lorazepam and temazepam. So if your woman is taking low-dose contraceptives, you need to switch them to oxazepam. Oxazepam. That's not even on here. All right. Okay, so those are your benzodiazepines. So again, to recap, temazepam or Restoril, lorazepam or Ativan, those are intermediate acting agents. And then flurazepam or Dalmane is long acting. So temazepam and Estazolam for sleep maintenance, and then flurazepam and clozapam to assist with falling asleep and maintaining sleep. All right, next up are BZRAs, benzodiazepine receptor agonists. These are good stuff. Long-term use of these drugs, though, can alter sleep microstructure, worsen dementia. They can also induce some strange behaviors, altered state of consciousness, maybe some sleepwalking, sleep eating, sleep driving. That's terrifying. Just other class side effects include decreased motor coordination, confusion, and anterograde amnesia. That's really terrifying. First up is ezoiclone or Lunesta. Indicated for treatment of insomnia. Not sure how it works, but it is a controlled substance. 2 milligrams immediately before retiring to bed can increase to 3 for sleep maintenance. Peak plasma concentration is occurring within 1 hour. Dosing, should take with or shortly after a high-fat meal. Interesting. We're talking about Lunesta. Can't drink alcohol in it because it's gonna produce even more of a sedative effect. Adverse events include headache, dry mouth, dizziness, respiratory system infections, and an unpleasant taste. What about Lunesta? Great. All right, next up, Zolpidem, or Ambien. We've all heard of it. Can produce a robust hypnotic component and improve sleep quality while producing less daytime impairment than other hypnotics. It's a controlled substance due to potential for abuse. Interestingly enough, dosage is different for males and females. 5 milligrams for females to start with, and 10 milligrams for males. Can up it just a little bit if we need to 6.25 for females, 12.5 for males. But we know that the side effects are going to increase with increased dose. 10 to 15 minutes after administration, the stuff is going to start working, can last for 2 to 3 hours. So this obviously is for our sleepers that have trouble falling asleep. Headache, dizziness, drowsiness are some adverse effects from this. Careful when prescribing Zolpidem with other CNS drugs that have depressive effects, obviously. Third up is Zaleplon or Sonata. Sonata. Works well for patients who have difficulty falling asleep, but not really a good choice for patients who have difficulty maintaining sleep because it's got a short half-life. So it's going to go bye-bye not too long after falling asleep. So 5 to 20 milligrams, rapid onset within 1 hour. So you take it right before you go to sleep, and it's going to be out of your system by the time you wake up, so no daytime lingering drowsiness. Headache is the most reported side effect, followed by dizziness, nausea, abdominal pain. Contraindicated in same use with sodium oxybate or Xyrem, and any type of fentanyl or valerian. So then we go on to the orexin receptor antagonist, orexin receptor antagonist. It's a new drug class. Two agents are suvorexant or Belsomra and lemborexant or Davigo. I've never heard of those. And then next up, melatonin receptor agonists. Ramelteon or Rosarem. These are all really hard to say. Oh, and for this one, you have to avoid administration with a high-fat meal. So that is that one. Then antihistamines are another class that can be used. That's my favorite one because I feel like they don't have a whole heck of a lot of side effects, some anticholinergic effects, but yeah. So one of the most used agents is diphenhydramine or Benadryl. We all know it. Powerful sedative with anticholinergic effects. Interesting fact, you could get a DUI if you were caught driving under the influence of Benadryl, so don't drive. And educate your patients that. Another first-generation antihistamine agent used for insomnia is doxylamine succinate or Unisom. This is the only one that's okay for pregnant women, is the Unisom, doxylamine succinate. So antidepressants can also be used, sedating antidepressants such as mirtazapine or Remeron, trazodone, and doxepin or Tylenol. First-line therapy is our benzodiazepines. Remember, we talked about the alazapam, lorazepam, and tenazepam. Oh, and they are approved for pregnancy. Nope, I don't think they are. Looking at table 41.2. on page 838. I don't think those are approved for pregnancy. Our first generation antihistamines, though, the doxylamine succinate, Unisam, that is approved for pregnancy. I don't think the other ones are. Oh, also first line is our BZRAs, our zolpidem, zaloplan, escitalopram, or Ramelton. So this table doesn't make any sense. This book is very frustrating. It doesn't make sense. It talks about these are the first lines, but then there's paragraphs down here that say different. So as far as the quiz goes, like this is where I struggle when taking quizzes because things are not cohesive. That's a frustration. So first line therapy, to recap, our BZRAs or Rameltion, the doxylamine succinate or Unisam for pregnant women. Second line therapy, alternating short-acting BZRAs are Zaloplan and Zopiclone with Rameltion. Also, our sedating antidepressants are trazodone, amitriptyline, doxepin, or mirtazapine. And then third line is our sedating anti-epilepsy agents, our gabapentin, atypical antipsychotics, quetiapine, olanzapine, and then our weird orexin receptor antagonist that I've never heard of, the suvorexant. So basically, first line for our patients are benzodiazepines, our BZRAs, and our first generation antihistamines are Benadryl and our Unisam. So that's basically what I'm taking away from this. There's a nice treatment algorithm on page 839 for insomnia. It goes on to talk about peds, melatonin for peds. I mean, probably for adults that would be good too, but they don't mention that. So I don't know. This book is absolutely frustrating. Geriatrics and women. Again, it talks about as a sleep agent, Unisam. Then it goes on to talk about some good stuff, patient education, and then good sleep habits, setting a bedtime routine, getting regular exercises, using the bed only for sleeping, some psychology for sleep hygiene, getting in bed only when you're ready for sleep. You're not getting in bed playing on your phone, farting around, exposing yourself to the blue light. You're getting in bed, you're going to sleep. Also avoiding stimulants such as caffeine, alcohol, and excess fluids, so you're not getting up to pee every hour. Non-vitamin agents are complementary and alternative medications. Melatonin, sometimes that's all you need. Does not induce sleep, but acts as a gatekeeper in the cascade of events. So it kind of puts your body in, a position to want to be more asleep than awake. It just messes with it's a hormone. So it enables the CNS to favor sleep over wakefulness. Also, another good root is the valerian root, traditional sleep remedy that's derived from the perennial herb Valeria officinalis. 30 minutes to 2 hours before bedtime, take a couple capsules, and you're good to go. So that's that. What's up?